here for this particular IC. Right at the outset, I would like to thank EPAO and AIOS for having accommodated us for this particular IC. Now, in ophthalmology, nothing is always, a clear picture. There are gray areas in ophthalmology. So, in each of these gray areas, so which is not either black or white, so we've chosen certain important gray areas which we would like to address. Remember, we are not trying to promote one over the other. It is every particular scenario has its own treatment algorithms and has its own method by which you can tackle it. So like they say, there are more than one ways to skin a cat, and not every way may be the right thing. So we're trying to decipher what is best for the patient in a different scenario. So I would like to first start upon a case scenario where we have a patient who is about 45 years old and who comes in for a refractive surgery. In fact, there are quite a few of these patients who are now coming in because they have finished tending for the family, they have finished tending for their children, and they want to do something for themselves, having the expendable income. So how would you tackle it? So my first talk today would be for So we have this 45-year-old patient who comes in for a refractive surgery. So there are various methods by which one could treat this patient. Now, presbyopia, as we know, is inevitable in middle age, and to treat presbyopia along with other refractive errors, you could either use a keratorefractive surgeries, or you could use something called as prelex, that is presbyopic lens exchange. The problem with keratorefractive surgeries, where you would have to go in all cases for a monovision, is that it's got quite a few limitations. As opposed to that, prelex is a long-term stable solution with binocular vision. So what are the limitations of corneal refractive surgeries? Basically, it does not address the root cause of presbyopia. Refractive surgeries done on the cornea can cause higher order aberrations and therefore can affect corneal contrast sensitivities, especially in these middle-aged patients as they turn older in age. And there's a higher risk of dry eye syndrome in these particular patients. Again, there may be a regression which occurs over a period of time which will require retreatment. Again, there's no long-term correction of presbyopia. As age increases, the presbyopia will tend to increase. And when this patient has to go in for a cataract surgery, the difficulty would arise in the IOL power calculation. On the other hand, in cases of keratorefractive surgery, in most of the cases, we would do a modified Q value treatment, also called as the FCAT treatment. So what happens is the non-dominant eye, you increase the Q value to make the cornea hyperprolate, and basically the depth of focus is increased. Whereas in these cases, though there is an increase in the depth of focus, there is always a problem of reading at a very close distance of 33 centimeters. So again, because of this monovision, there is a reduction in the stereopsis. Not all cases may undergo a good neuroadaptation, and therefore the results may not be always successful, and it basically compromises the vision between the two eyes. Presbyopic lens exchange, on the other hand, treats the cause of presbyopia along with the refractive error at the root cause, that is the cause of the lens which has now become dysfunctional. So you can have your normal clear lens replaced with either a multifocal or an EDOF lens, and it gives you a spectacle independence for all distances, far, near, and intermediate, and it is a permanent solution. Again, there is no risk of developing cataract. So it's beneficial for all patients who are more than 45 years of age, who are looking for freedom from glasses, patients who have started developing cataracts but who are still not eligible yet for a cataract surgery from the visual point of view, people with active lifestyle who want to engage in sport activities, and patients who want something permanent to correct their presbyopia. And basically this can treat all types of refractive error, whether it's a myopic, a hyperopic, or pure presbyopia. So literature has also proves by various studies that the superiority of prelex over corneal refractive surgery. So basically, like I said, it is stable and permanent, no regression. It gives you a binocular vision, better contrast, no higher order aberrations created, prevents cataracts in the future because your crystalline lens is out, no issues like dry eyes unlike a LASIK or a PRK, and it is a customizable procedure because you can have your own choice of a IOL which you choose. Again, like I said, all forms of refractive errors can be treated. So you can either use a multifocal IOLs or the EDOF IOLs in these cases depending upon what the patient's needs are. A short video just to demonstrate, it's very important here to understand that this is a patient with a clear lens, so one needs to perform this procedure after being thorough with his cataract surgeries in elderly patients. A good rexis, minimum 5.5 millimeters with a good cover of the IOL is important in these cases because we cannot have a decentered lens, especially in an elective procedure like this. Again, a good multi-quadrant hydrodissection and a hydrodelineation helps because these cataracts are soft, so you don't need to use any phaco power. A good soft cell technique to prevent any endothelial cell loss. Basically, it's an elective technique. Being an elective technique, you can't induce any other complications or any other problems. So again, like you see, we're using only an aspiration technique here. We're not going in, hardly any phaco power is being used. The nucleus is already freed. And this particular case, we are able to do it without a second instrument. So no side port has been created in this case. And just with playing with the vacuum and the flow rate, the entire nucleus can be easily aspirated. Again, a good cortical cleanup with polishing of the posterior capsule as well as the rim of the anterior capsule is very important to prevent PCOs. Remember, these are young patients. Lens epithelial cell hypertrophies can occur and they can develop an early opacification of the posterior capsule or the phimosis of the capsular rexis margin. So again, a proper cleanup is very important, and this can be followed by the lens of the choice. So in conclusion, it is important to understand that presbyopia is a problem with the lens. It's a dysfunctional lens, and it's always better to treat a particular condition at the level at which the dysfunction occurs. And treating presbyopia on the corneal plane is like punishing the cornea for mistakes of the lens. I know Rupal is going to not agree with me in this, but again, like I said, it is horses for the courses. So there are different cases where one would need to treat the corneal cornea also with a corneal refractive procedure. So I'll hand over the mic to Rupal to counter this.
Thanks, Dr. Nitin, both for setting the base as well as calling me here for this wonderful IC. It's really interesting to see that all the seats are occupied, Dr. Sandeep. So it is a dilemma when a 45-year-old comes to you for for getting rid of glasses. And they are demanding people. They are in some prime of their age and they are used to having their ways. So they are going to demand perfection. They are going to demand no complications and safety, because also they are in the primes of their lives. They are the earning members. They want to play it safe. So for me, if there is a clear lens, I don't want to touch it, because you don't know when the cataract would develop. For my own mother-in-law, I treated her cataract at 82 years of age. So she didn't need a cataract surgery till that long. So why unnecessarily remove a functional lens if there is a choice? If you ask me, I'm definitely above 40, I hate to admit it. I still don't need to wear glasses. I have 6/4 vision in each eye. And I can still read all my WhatsApps. You can check my phone. So some of the lenses do remain functional. They do provide accommodation. So not all lenses should be punished for no crime of their own. And just to give you that satisfaction that you had given some correction. So with that basis, I would like to just counter argue whatever Nitin has said. So the features of a 45-year-old typically is that they have difficulty for near work, and that is just commenced. So they're still grappling with the fact that they have aged. On top of that, if you're going to add this insult of telling them that you would need a lens exchange, it's similar to a cataract surgery, but without a cataract, it is going to make them feel scared. Most people would take a step back and say, what are you saying? Do I need a cataract surgery? And that's something that's going to be in their decision making also. They still have some accommodation left. They generally have not significant lens sclerosis at 45, and they may require surgery anytime after 15, 35 years also, as I said. And there are benefits of refractive surgery. It is an extraocular procedure. Whatever you say, even an uneventful cataract surgery can lead to sometimes CMEs. It can lead to a PC rent for no reason, just the patient moving slightly on the table, and you could end up in a grave complication. And if a person can't tolerate the press beyond, where there is a micromonovision with increased depth of focus, then it is difficult for them to neurally adapt also to these multifocalities and trifocals and extended depth of focus lenses, because it means that their neural system is not just ready for any compromises, and then they are better off wearing glasses and not do anything of this sort. So what is important is that the refractive surgery can give you a remarkable accuracy, because you are going on the cornea, and you would find that if you compare LASIK results to today's modern day higher order premium lenses, you would find that LASIK results are much safer, especially with the advent of femtolasers. You have special parameters where you can cause a Q wave change, so Q value change, which means that you can increase the depth of focus by making the cornea hyperpolate. And most of the laser platforms are not giving you that option. And you can also take care of the corneal wavefront aberrations to achieve a higher quality of vision. So today, the contrast sensitivity and the quality of vision is sometimes even better than what you can get with your glasses or contact lenses. There is possibility of enhancement, and it's not very difficult because you already have a nice femtoflap there. And there is no interference with the later cataract surgery. In fact, you can also get away with a monofocal lens post, if you've done a press beyond like surgery, you have induced hyperprolacity on the cornea. So later on, when you actually need to do cataract surgery, just a monofocal lens will also give that added advantage of depth of focus. So you won't need to compromise on your quality of vision even then. So it definitely becomes a much more lucrative option. The disadvantage of prelex is that patient instantly loses natural accommodation. So if you have to put in a monofocal lens, it has to be like really a monofocality, where you have to induce, so the dominant eye kept absolutely metropic, the non-dominant eye would require to be at least 1.5 to 2 diopters. Some patients with multifocal lenses are unhappy with glare, halos, loss of contrast sensitivity, and they need not be as perfect a result as refractive results. And the risk factor is higher than extraocular surgery. And I would say that I have an example where I treated my own husband. He was 6/4 each eye. He was becoming presbyopic. I treated him at 46 years of age, exactly the same scenario. We did press beyond. It's been 14 years now since he has undergone Press Beyond, and he's still without glasses. And people who know my husband knows he's an avid reader. He is into stock market, so he's on the computers all the time. And he loves to drive, so we have also taken driving trips to Himalayas from Vadodara. And he is not needed to wear glasses. We did need to do one enhancement 5 years back, but he's still without glasses, so I rest my case. Thank you.
Thank you, Rupal. I think we'll have, discussions at the end. We now come to a different scenario here that achieving multifocality, what are the various methods? So we have Dr. Shilpa Kodkani who will be now talking to us about multifocalities with monovision. Following this, we'll have Dr. Nikhil Nasta who's filling in for Dr. Vavikar because Dr. Vavikar couldn't be here due to an emergency to talk about multifocality with EDOFs and multifocal IOLs. Shilpa.
At the outset, I thank our chief instructor, Dr. Nitin, for having given me this opportunity. And it's also a great pleasure today because I'm debating with my student, Nikhil. So it's icing over the cake. So, well, multifocality in today's era. So I'm going to talk on monovision. Monovision basically is correction of the distance vision in one eye and the near in the other. So it addresses your correction of presbyopia. And in the past 4 decades or more, we have been doing it in contact lenses, refractive surgeries, and now refractive cataract surgeries. Well, I'm sure all of you here would agree with me that our most happy patients are the ones with monofocal IOLs. So, having said that, we can't leave a patient presbyopic. Like Rupal said, her husband would have killed her if she couldn't give him good near vision. So this definitely is an issue. So monovision concept, wherein distance vision is corrected in the dominant eye and near vision in the non-dominant eye, of course there is going to be some amount of neuroadaptation, but that is there in all the premium multifocals, trifocals, EDOFs, whatever it may be. Now, there's a very simple way of checking dominance in which it can be done very easily in your OPDs, where you make the patient look not that way, ma'am, this way. Okay, a little further away. And in your vision chart, the first letter is what you, 6 by 60, is what you project. And you close one eye and then the other. So the one in which the object will move is the non-dominant eye. In the eye that it doesn't move is the dominant eye. But of course, there have been problems in the past because monovision used to be emetropia in one eye and almost 2.5 and sometimes even 3 diopters in the other. So this huge amount of anisometropia definitely compromised on stereopsis and contrast sensitivity. And of course, the problem of intermediate vision, because nowadays all of us, we don't care about our distance or our near. Our intermediate is something that is very, very important to us. And that's why multifocals, trifocals, EDOFs, all these came in. But premium IOLs, there are problems. Induced aberrations, dysphotopsias, reduced contrast sensitivity, poor night vision. There is extra time required for neuroadaptation as compared to monovision, and the Z syndrome, of course. EDOFs do reduce these phenomena, but near vision is not satisfactory. So what have we really achieved here? So just like in the past, PRK was there and went out. And then it did a comeback with a little difference where mitomycin was used. We have trans-PRK now. And similarly, even Amitabh Bachchan came back with a humongous bang because he changed his strategy. He started acting his age. So similarly, monovision came back with micromonovision, wherein you just make the non-dominant eye about 0.75 to 1 diopter. I normally prefer to make the patient about 0.75 myopic. But I will also tell you how I do it. Well, micromonovision, there is less anisometropia as compared to the earlier monovision. No glare, no halos. Like I said, monofocals are the best lenses even today. We still don't have an answer for our IOLs where we can get good multifocality with no glare, no halos. Otherwise, I myself would have got it done long back. I'm waiting for that lens today. And it's also useful in different ocular comorbidities. Refractive surgery, well, presbyopic correction has these three basic interrelated factors: visual acuity with no glare halos, depth of field, and no dysphotopsias. There have been so many studies being done even earlier with monovision, not micro, where they have shown good results, but there the problem was intermediate vision. Now, the recent studies have also come in where this is a literature search which was done, and it was seen that there was decreased dependence on spectacles, which was 93%, little or no use of spectacles post-operative for computer use, as well as for near vision. So today, the terminology has changed. It has changed from best corrected visual acuity to best spectacle-free vision. So, and with monofocal IOLs, you can also address the issue of astigmatism with a monofocal toric. So there is this whole checklist or an armamentarium of IOLs that we have today, and I'm sure an honest to God opinion would be monofocal IOLs. Because you sleep well, your patient sleeps well, neither of us have coronaries towards the end of our careers. So all are possible. Of course, we do all the armamentarium which is there. I wouldn't say I don't do EDOFs and I don't do multifocals, but yes, patient selections, more chair time, high costs, so more the cost, more the expectations, all these problems being there. And what I do normally is I make my patients slightly myopic. In the dominant eye also, I don't achieve emetropia. I make them slightly, about 0.2 to 0.3 myopic, as you can see in this chart here. And the non-dominant eye is about 0.6 to 0.7 myopic. So this is how I try to achieve it, wherein my patients get about a 6/9 vision with one eye, but binocular, they are 6/6. But of course, when we are planning on micromonovision, it is very important to counsel the patient, just like in what we do in multifocals or trifocals, that the other eye has to be done quickly. That is something which is very, very important. And always, of course, if the cataract there is significant difference in the extent of cataract. If that is there, then of course you'll target the more cataractous eye. But otherwise, if it's more or less the same, then I would prefer to treat the dominant eye first and then go in and seeing the results. Of course, we are quite sure of our results today because of good optical biometers. And this is a study which has been done even in the panoptics IOLs, where there have been halos, starburst signs, glare, all these things. Reduced percentage, but look at that percentage of 16%. It is quite phenomenal. So we have done a study in our own center with 100 eyes, 50 patients, wherein we use the monofocal aspheric, and in some cases where astigmatism was there, we use the toric, and we've done it with the lens being constant, that is the Acrosoft IQ. I have no financial interest. This was just a study, and we've seen that most of our patients came up to 6/9 uniocular and 6/6 binocular, and N8 to almost N6 part in most of these cases. So the exclusion criteria for us were ocular comorbidities, significant dry eye symptoms, strabismus, amblyopia, or anything that compromised on binocular single vision. So the advantages being you can give good distance, intermediate and near vision, but with micro monovision, not the monovision of the past. Reduced reliance on glasses for patients, improved night vision, enhanced contrast sensitivity with our good aspheric IOL designs, and you can also do this in the Indian intraocular lens segments, and it also offers, because of this, cost-effective solutions. This is, which is very, very important if you want to target the whole range of patients that come to you. So I would say, yes, multifocality uh, is definitely there. We have EDOFs, but we have also seen patients with EDOF lenses who have, where we earlier thought EDOF will take care of everything. There will be no glare, no halos. But sometimes we do see these patients, in spite of all the ray tracing and everything, if you have the whole armamentarium of diagnostics, then even then we do have those surprises. But with monofocals, those surprises are not there. Like I said, no coronaries, very important. Thank you so much.
Thank you, Shilpa. I now call upon Dr. Nikhil Nasta, who will be speaking in favor of multifocality with EDOFs and multifocal IOLs. Give it back to your teacher.
Okay. Thank you so much, Nitin sir, for including me, and Shilpa ma'am for teaching me all that I know. In her hands, you put anything mono, trifocal, EDOF, they are going to see very, very well, and we know that with her expertise, and of course, the way she is. So, I'm going to speak a little bit on EDOF and trifocal technology, which is the buzzword, and it's what everyone is wanting to do. I use a lot of these in my practice, but I'm also a fan of monovision. It's a very tailored approach. So I'm just going to give you a fair view and not take any sides. What we are doing here is everybody wants no dip in their depth of focus. That is the prime thing, more than the quantity that they are seeing. I believe it's all about the quality as well. I may give them 6.6 and 6 and everything, but with glare and halos, they're not going to be happy. I may give them monovision, but if they are not happy with being myopic in one eye, they are not happy. So whatever you do, you're never going to win truly. You have to be very sure about that. Hypothetically, I'm presenting a case. He's my friend Mayav. He's a 42-year-old male emetropic businessman complaining of glare and halos at night. Asthmatic on inhalers, how will he spend his time? He uses the computer, he likes to check his Insta feeds, and he reads and drives occasionally. His ocular examination is showing a PSC, OD more than OS, and everything else is normal. This is what he has, and the fundus is absolutely clear. So he says, I've never used glasses, doc, and will I need glasses after surgery? And you're like, oh, okay, now what do we do? Okay. IOL options, we have monofocal plus IOL with monovision, EDOFs, trifocals. Now, in the monofocal, monovision things, we are depending on neuroadaptation. The brain has to work and to adapt. Whereas in the EDOFs and the trifocal, all the heavy weightlifting is done by the optics on the lenses. But still, it is a blend of both always. So, we are going to debate EDOF as well as trifocal and see which one is going to suit him the best. This is a debate I had done with my friend Manik Nicholson, and that's what I'm presenting. Monofocal lenses give you a single focal point. The center near two focus is there in a multifocus lens, and EDOF lenses have an extended depth of focus zone. So this is the difference in the physics behind these lenses. EDOF lenses, because they have this extended zone, they don't really cause glare, halos, and whatsoever. So for vision, both near and afar, EDOF IOLs are the star. No more squinting with strain. Clear eyesight you will regain. Now driving and readings are on par. That's what EDOF is doing for him. Okay. EDOF basically has two transition elements in the central 2.2 mm area. Small plateau of 1 micron stretches the wavefront to create a continuous focus. There's a very discrete change in the radial curvature. This is how the physics of the lens is, and that's explained over there. But There is going to be some loss of contrast for sure because it's a focus, not a single point. It may depend varying on the pupillary size, how much is the pupil like. And if it's decentered, the results won't be as you expect them to be, which is true for any premium IOL. A well-centered Rexis which has a well-centered lens along with your Purkinje images is good. This is the modulation transfer function, which is showing us the comparison of a mono with an EDOF and the defocus positions. If we go further, EDOFs have a posterior achromatic diffractive pattern with an ecklet design. It's an achromatic technology. Again, there is a little bit of glare halo, which is going to happen, but not as bad as you would have with a trifocal IOL. This is the monoocular defocus curves at 6 months, comparing a symphony and a monofocal control. When you look at the eye hands from J&J, this is a smooth continuous transition of power from periphery to the center. There are no demarcation lines here. There's a tiny central plateau which produces a local change in the refractive power, and it has a high range of diopters available. So there are no photic phenomenon, and there's a minimum intermediate vision also that they get here. If you compare different lenses, this is showing us the defocus ranges. For Vivity, it's pretty low. Okay, so these are just some graphs and technology behind it. So EDOF and trifocal, when you compare them, the defocus for a trifocal is very evenly spaced out at near, intermediate and distance, whereas in the EDOFs, it drops down near the near parts. When you go in for the trifocal IOLs, you get the best at all distances, excellent distance, excellent intermediate, excellent near vision, and the dependency on glasses goes away. So I always tell the patient, you're not going to see everything all the time, you will see everything most of the time, but sometimes you will still wear a glass which will be more like a magnification. It's not a chashma as such, it's more like a magnification for you. Also in the font sizes, if they just increase it to a larger font size, they get around that also really well. The quality of vision is pretty good. So with trifocals, your sight is always bright. Near, far and mid-range are just right. From books to the road, no glasses bestowed. You'll see every detail in sight. That's what it is. But different options available, AT LISA, span optics, fine visions and so many more. They all have slightly different technology relating to the rings on them. So in the AT LISA, it's a pupil independent style, but there's a loss of optical quality at bigger pupils. Bifocality in the periphery, and centrally it's a 4.3 mm trifocal design. In the pan optics, it's non-apodized, higher distance and intermediate light energy. Centrally, there's a trifocal design 4.5 mm and it has monofocal periphery. If you look at this graph here, it's showing us intermediate. In the pan optics, we have a good plus 2.17, and it's also showing us the light energy, so the contrast loss we can see here, and the material and the diffractive system. It's just comparing different types available to us. So pan optics, which is very popular, it has a central diffractive zone with a 3.25 near rad, almost a 2.2 intermediate ad, and it's aspheric minus 0.1. This is what the graphs look like, and it's a very promising lens. It's a very forgiving lens. It's nice. The visual acuity graphs are also seen here, the defocus curves and the MTFs without correction, which are all very favorable. The glare and halo, of course, does happen, but it's much lesser now. It's almost the same with the different kind of lenses, but it's a thing they have to live with and they have to accept. So you counsel, give a lot of chair time pre, so you don't have to give a lot of chair time post. So with an EDOF and a trifocal comparison, long distance driving is very good. Mid-range is also very good. But in the near, trifocals are a tad better. But if I have a smartphone which I can, zoom in and see, I don't really care much. Like I said, I'm more of a quality over a quantity. I'll buy something which is high quality more than just a lot of rubbish. Need for glasses after surgery may be minimum in EDOF for the very fine print, but many people get around this. They have problems with reading menus in dim lights and restaurants, but that's fairly manageable. Nighttime halos with EDOFs are minimal, but with trifocals, yes, they do happen, and they can be very annoying. Patients may say, I don't care much, I don't drive and all, but they come and sit in your OPD and they pick your brain on that. Okay, so can we use EDOFs and trifocals in all our scenarios? In a glaucoma, maybe I'll opt for an EDOF, not a trifocal. In a high myope, in a post-LASIK, in a post-RK. So certain cases we can use certain technology, but we have a whole basket. So we have solutions for everyone. I want to highlight this lens that I use. It's an Autofocus Pro. It's an Indian lens made by my mentor, Dr. R.C. Shah and Dr. Kakaria. And this gives us a very excellent depth of focus. And we've checked it, we've done a lot. It's improved technology, it's hydrophobic, and it's a good size to fit in the bag. So if you haven't tried it yet, you must try these. These are giving very promising results. This is just the checklist. We'll skip this. These are just some research done. We'll skip this also. So if I have to conclude, I don't think anything wins. Mono is good, EDOF is good, trifocal is good. You have to select wisely. Thank you.
Thank you, Nikhil.
For my friend, I didn't operate on yet. I told him we'll wait. But I would do an EDOF actually. I would do an EDOF. I would keep him slightly micro mono. That's what I would do. So for my mother-in-law, I had done a monovision because she doesn't read or drive or anything. For my dad, I had done an EDOF because he's always very active. And for my mom, she likes to play cards, so I had put a trifocal. It depends what you want to.
Thank you. We now go to the next scenario. In spite of using all the best technologies available today in our preoperative work of the patient, we still land up at times with refractive surprise. So how would one treat this refractive surprise? How would we make this patient happy again? So Dr. Sandeep Nagwekar, who requires no introduction, is going to be talking about treating a refractive surprise with an IOL exchange. And this will be followed by Dr. Sujata Mohan, who is busy in another IC and will be joining us soon, who will be speaking to us on using a piggyback lens in treating a refractive surprise.
So Nitin, thank you for inviting me. Is my opponent coming or she has given up? Okay, so there we are. Oh, sorry. So first of all, the topic says I had a refractive surprise. So the first thing we have to know that I am the surgeon. If I am the surgeon, I know very well what I have done. I know and I will recognize the problem immediately, immediately post-op. So this is the main thing. If you are the surgeon and if you're going to recognize the problem immediately, and if there is no easy solution in sight, by easy solution I mean, suppose it was a toric lens and the lens has not been positioned properly, you can rotate the lens. Or if there is a power problem of about half a diopter, then you can either capture the lens anteriorly or do a reverse capture. And if these solutions are not possible, then in my opinion, the best solution is IOL exchange. Now, why IOL exchange? First of all, it's very easy to perform in the first 3 months post-op. And it's not difficult to perform even up to 1 year post-op. I have done it even 2 years post-op. The power of the IOL is known and the refractive error is known. So because of which you have all this data in hand, it makes it very easy to predict the power of the IOL that you have to now secondarily implant in the patient's eye. And even if the patient has been operated by someone else and the IOL power is not known, in modern technology using optical biometry and substituting the lens status as pseudophakic, it is very easy, and if you know the material of the lens, you can recognize it on the slit lamp. It's very easy to predict the power of the IOL that has to be put in the other eye. The main thing that has always been touted against lens exchange, that it is very difficult to perform. I wish to show you with a small video that it's not very difficult. Now here is a case operated by me, a patient who had a PanOptix trifocal put in her eye, and she was absolutely 6'6" and 5". She deferred this decision till around 3.5 months post-op. But when she was not very comfortable with the glare and halos, and she was a VIP, I decided to go and exchange. It was a femtocataract. Now this is where the most important thing. You take a flat blunt tip spatula and slip it under the anterior capsule and go as far as possible to the periphery. Now, this is very important that you open that capsular bag that has shrunk. And with this fat tip blunt spatula, it is quite easy. So go around 360 degrees, especially above the haptic. Now, that's that little adhesion that needs to be broken. And I think the game after that is quite easy. So now you go in with heel on, slip your cannula under the anterior capsule, 27 gauge cannula, watch those bubbles as well as the flow of the liquid wave as the visco completely dissects the posterior capsule of the lens from the posterior surface over there. Now, with the help of a simple dialer, you start rotating. When you come towards that edge and you find that the tip of the haptic is not going further, it's time to wait, push it back again. Don't be too aggressive. It's the reason why it's not happening is because the other haptic is not loose. So now go on the other side, put your dialer over there, and gently nudge it out of the capsular bag. Now, this is 3 months post-op, and you can see that it's not very difficult at all. Now, this one will get free. Now you have, with a simple movement, you will have the entire lens in the anterior chamber. And once you have this, then the rest is quite easy-weasy, okay? So next thing, you pull the haptic out of the eye, and then go in from the side port and hold the IOL with IOL holding scissors and use the IOL holding forceps and use the scissors to cut this IOL into 3 or 4 pieces, depending on what is required. This was a 30 diopter IOL, so the IOL was quite thick in the center. Now we have an even better solution. Dr. Neha Dolakia has provided us with a very good instrument, an IOL cutting scissors, which is ultrasound based. So you can just fix it to your phaco handpiece and do this easily without even having to open the jaws. You must always keep the AC well inflated with viscoelastic so that there is no risk of rupturing the posterior capsule. Anyway, the blades are always blunt on the other side, so it's very, very easy. All you have to do is make sure that at all times use plenty of viscoelastic. Don't be stingy over there, and you can easily get this out of the eye. For reasons of brevity, I'll skip to the last piece. You have to use now a dialer to feed it in properly into the IOL holding forceps and gently get it out of the eye. And all this is through the 2.2 millimeter incision that you began in the first place. Now you inject the monofocal toric, and it was, as you saw, a toric, and you put a toric back again. And lo and behold, the patient's vision was 6/6 unaided. There was no induced astigmatism. It's very simple. All you have to do is basically make sure that you free the IOL from all sides. Now, why not a piggyback IOLs, as my esteemed opponent will speak on? Remember that 2 IOLs occupy space, whether both of them are in the bag or one is in the bag and one is in the sulcus. This often leads to iris chafing and the development of the UGG syndrome. It can lead to both a pupillary block glaucoma as well as an angle closure glaucoma. And it can also lead to interlenticular interface opacification. This is well known and documented in the literature. Now, the sulcoflex toric IOLs are notoriously known to rotate within the sulcus, leading to patient disappointment as astigmatism reemerges. And the bioptic pseudophakic vision system does not provide great quality of vision. Speak to someone who has had a bioptic procedure. He has had 2 lenses, either both in the bag or one in the bag and one in the sulcus. They always complain that when they go out at night, they always see that streak of light emanating from all street lights. That is because of the light getting reflected from the second IOL, okay? And they also complain of loss of contrast. The vision is not as good as the other eye, which may have had a perfect IOL, and other photic phenomenon. So the benefits of IOL exchange, that any IOL, whether it be toric or non-toric, whether it be mono, trifocal or read-off, can be easily implanted. You can once again give the patient great quality of vision. It is a single-step solution to provide the internal refractive element of the eye, which comes somewhat close to the natural lens. And we all know that today's IOLs come quite close to the natural lens, though nothing can ever replace it. And once performed, the patients are very happy and secure in the knowledge that no further IOL-related complications are likely to surface and that no further interventions may be required as explantation of piggybacks that happen sometimes. Thank you so much, very much for your time.
Thank you, Sandeep. We'll now have Dr. Sujata Mohan talking to us about using a piggyback IOL for treating of a refractive surprise.
So good morning, everybody. At the outset, I'd like to thank Nitin for giving me this opportunity. Once again, we have been doing this course for the past 4 or 5 years. And I'd like to thank AIOS and APAO for giving this opportunity to us. Pardon? No, there's no audio. Is it coming? Sorry. I have to go to the first slide. Okay. Okay. So my topic is I missed the bullseye. So I'm going to show you a series of cases. This was a 57-year-old female with an immature cataract, and she had a cylinder of -4.5. You can see she has a clear case of pellucid marginal degeneration, has a 6.7 diopter cylinder, and topography is showing a 7.7 cylinder. So we did the calculation based on the Barrett's calculation, and we ordered for a customized toric IOL. And you can see that the recommended placement is somewhere around 150 or something. And so the lens was placed in that axis, but post-operatively, she came up with a -7 cylinder. From -5, she went into -7 cylinder. So what do we do in this case? She's a case of pellucid, and she's already been using contact lens. The wiser decision would have been to just put a non-toric lens and just ask her to continue to wear her lens. So, but since we've already placed a toric, we decided to go use a Zalvida toric caliper tool to calculate the angle of difference in the degrees and measure whether the intended meridian from the toric alignment, which is already present. And so we did get a different. You can see it is almost at 90 degrees, which is surprising because her cylinder actually is showing around 150 degrees. So this is what we did. In a week's time, we rotated the lens. It's a custom toric lens made by Ocare, no financial interest. But they're quite easy to rotate. It's important that you put enough viscoelastic because you don't want to rupture the bag. And so just gently, if you take a longer time, then some fibrosis would have formed. But since we did it within a week's time, it was quite easy to rotate. And once we rotated into position, you can see that I'm using actually a Callisto, and this I usually mark even if I use a Callisto because sometimes the Callisto doesn't show up very clearly, or it can just stop in between, which has happened to me once. So so you can see the Callisto is also showing that it's in a good position. So post-operatively, she did well. She had a very small -2 cylinder. So in case of residual uncorrected refractive cylinder, you repeat all the pre-op tests, IOL master, lens trace, do an eye trace. Special formulas like Barrett, TrueK, Kane or EVO formulas can be used. Check your topography and pentacam, dilate and check the position of the IOL, redo the calculation. High incidence of errors and abnormal corneas. So it's better to go back to their contact lenses, but that gives them the best quality of vision. So again, a case 2 is a post-RK case with an immature cataract. The problem is with RK is the IOL power calculation. You can see a conventional method is showing a 17.5, whereas calculation by Barrett's is showing a maximum of 21. You have to anticipate a hyperopic shift in these patients, and you have to explain to them that's a possibility because all the refractive surgery patients, they expect a plano, like what they had immediately after refractive surgery. And another problem with post-phaco cataract surgery is that the incisions can open up. So whatever you do, make sure that you have low flow parameters. Don't increase the bottle height too much. And if you're a good phaco surgeon, you can go ahead with any method that you want to. And placing the incision is also very important. Place the incision at the limbus. in between the two RK incisions, so that you don't open up the incisions. Otherwise, you can even make a conjunctival opening and do a scleral opening. So then now in this case, fortunately, I do have cases where it is opened up, and in this case, fortunately, everything went well, and the lens was implanted in the bag, and she did extremely well. So she had a minus 1.75 cylinder at the end of the procedure. So the problems is biometry is the main bugbear. RK wound gaping has to be taken into consideration, and most of these patients have to be advised about the hyperopic shift. So third one is a hyperopic classic patient, was very keen on multifocals. You can see a very centered ablation. This is what comes up when you do a hyperopic ablation. Most of them show up as keratoconus because it's a hyperprolate cornea. But you can see it's a very well-centered ablation. So we decided to use a Barrett's formula as well as a Hill RBF formula, which more or less synchronized, and we went ahead and did a multifocal IOL for her. And she did very well. She had a 6x6 and 6 vision. Multifocal IOLs, most important point is well-centered topography, IOL master, Barrett's formula. There are a lot of newer formulas like Hill RBF, and more importantly, a good counseling is very important. Do not attempt to do multifocal IOLs if you have a decentered ablation like this. So next is again a patient who had a myopic classic with improving to 6.9 minus 2.5. You can see she has a mild decentered ablation, and the maximum power to be implanted was 20 diopters, and that's what we did, and the axis was 110 degrees. And you can see the post implantation, the placement is exactly where we desired. And post-operatively, again, she had a minus 2 cylinder. And in this patient, so we decided to do, because the cylinder was very small, we decided to do a bioptics and did a laser to correct her minimal astigmatism after a period, waiting for a period of 3 months. So this is some of the post-op things that we did. So the options are bioptics, Wavefront optimized PRK, contour vision can be done. This is a case of high myopia with a residual cylinder of 2.5, and which we did a rotation just similar to what I showed you. So I'm just skipping this video. So case 6 was a high residual myopia. The options in this case was, because this was actually referred to us with a minus 7 diopter cylinder, probably because of the wrong IOL placed. So the options were PRK or an IOL exchange with proper power IOL. The third option is a sulcoflex IOL in the sulcus to correct the residual power. The power calculation can be done like this. If you have a hyperopic error, you multiply it by 1.5. If you have a myopic error, you can multiply it by 1.3 to get the IOL power for hemetropia. So the sulcoflex lenses are made by a company called Rayner, which probably is a monopoly. And so they are specifically made to be placed in the sulcus. So they have a concave posterior surface and a convex anterior surface. So it protects the lens from touching the other lens, and it can be implanted into the sulcus very effectively. And like I said, once we do that, it corrects the power, and it's quite a simple method of correcting the residual power. See, if it is somewhere around minus 2 or minus 3, you can still do a laser. But when it is minus 7, you can, the sulcoflex IOL is a good option. You can even think of phakic IOL as an option for these patients who have higher residual errors. And this goes in very nicely, and the patient had a very good outcome. So a little bit points about sulcoflex IOL. It's a hydrophilic IOL with a 6.5 millimeter optic and 13.5 overall length. It has a concave, like I told you, it's got a concave posterior surface and convex anterior surface with a 10-degree posterior angulation. That is very important. That ensures the separation of the IOL from the iris anteriorly and the primary IOL posteriorly to prevent iris chafing. So refractive surprises can happen after post-LASIK PRK. You can get it in ectatic corneas, vitrectomy with silicone oil. So you can use newer formulas like Barrett's, Hill, RBF, Kane formula. Importantly, you have to do a topography and tomography in all these patients. Management can be IOL rotation, explantation and reimplantation, sulcoflex IOLs, and phakic IOLs to achieve your emetropia. Thank you.
Thank you, Sujata. Continuing from there, we'll now have our keynote address by Dr. Anand Deshpande, who will also highlight about how to tackle post-operative refractive surprises.
Hello, okay. So how to tackle post-operative refractive surprises in our day-to-day practice. So we are not, we will be very happy if our patients fly to USA for a treatment after refractive surprise, but this doesn't happen with all of us because we have to handle our own patients. And the monofocals, the EDOFs, the multifocals, so many things we are telling to the patient that you will be the glass free. And after monofocal implantation also, so many patients are telling that I cannot see for near. So these kind of things are happening nowadays. So patients are demanding more. We are also telling patients that you will be glass free and like this. So for all these surprises, how to tackle, because our patients we have to tackle our own by our ways. So what are the problems and from where the problem starts is a pre-operative, some patients with a biometry errors, sometimes inappropriate IOL formulas if we use pre-operative astigmatism, which we have not seen for the pre-operative astigmatism. Some in operative cases like a surgical induced SIA, we cannot say how much will be induced. Sometimes it gets more induced. Misalignment of the IOLs, surgical complications, inverted upside down IOLs, anything can happen at the time of surgery. So all these pre-operative, operative and post-operative. In a post-operative complications like anterior lens capsular phimosis, lens tilt, PCO, these all are the problems where the patient will have some kind of refractive surprises. So in our day-to-day practice, 80% of the patients we are giving a good chair time, counseling the patients and convincing them for the glasses. So 80% patients we are sending them back with some kind of satisfaction. But in a 20% of cases, they will not accept any of your things. They want some correction has to be happened. In these cases, what to do? So there are some cornea-based surgeries like LASIK, PRK, LRIs you can do. Some lens-based procedures like sir has shown the IOL exchange, madam has shown the piggy bag IOLs, IOL redialings are there. So I will just show my three cases the same way we have handled, but sometimes something wrongly happened. This is a 50 years male patient having a mature cataract. Implanted, our counselor has counseled them for a multifocal IOL. I was not knowing, and they told that you will be glass free, and surprisingly, the post-operative refraction was -6. And I have done the very nice Rexis of 5 millimeter and implanted the plate haptic design multifocal IOL. So it was very difficult for me to explant the IOL. In that case, I have done the Sulcoflex IOL. Nomograms for Sulcoflex IOLs, like madam has told, the Rayner has they have patented this Sulcoflex IOL, and they were using, they have a monopoly of the lenses, but now the good Indian company like IOCare has came in the market with the Sulcoflex IOL. Also you can think of a phakic lens also you can put in the like a piggy bag IOL. So this was you can see that multifocal IOL has been implanted with good rings are there, but post-operative refraction was -6. I have done under only topical. I have taken so much time that what went wrong for this case, but I found that only this is the solution in front of me, that I should go ahead with the piggy bag IOL, because I was not sure that if I am trying to explant the lens, definitely the whole bag will come with the lens. So I have just implanted the lens inside the sulcus, and patient is happy, I am also happy. So second case was 55 years old male implanted with a monofocal IOL, and surprisingly the post-operative refraction was -3. patient was sometimes they also very keen that no, why -3? No, it's good for you that other I will do you for 6 by 6. This I will work for near, this I counsel lot of times, ki, "Baba, this is very good for you, for one I will work for near and other I will work for distance." But the patient was not understanding. So I have gone back, what went wrong, that definitely the IOL power was wrongly chosen. So I have taken a decision that I should exchange the IOL. So I have done the IOL exchange under topical anesthesia, but I use scaffold IOL technique. So many times what happens, we are always worried about the PC. So if you just lift the lens from the bag and put one more lens inside the bag. So the PC will be tightened and it will be away from the, see, I have just lifted the one lens and now I am putting the monofocal IOL in the bag itself. If it goes down, you are away from the PC, and PC means you will never touch the PC. And then you lift the first IOL, cut it and remove it. Very simple. So there are two lenses you can see. That one is now going inside the bag, and second I am just lifting and cutting. So this is the second IOL. So second also no need to cut whole or 3-4 pieces. You just cut it triangular shape, slightly increase the incision from 2.2 to my incision is 2.2. I have just increased to 3 millimeter, might be, and just cut it like triangular. You remove that piece of that triangular cut IOL, and whole lens you can remove. Now you have to just remove the first, and then from the incision you just rotate this lens like this. So definitely it will come out. So just move like this. And third case is a 50 years female. I have implanted with J&J IOS lens. I have committed her that she will get a very intermediate good vision, and taken a good money also. But the patient had a refraction of -1.75. I have counseled her for exchange of IOL. She told me, no, I don't want any surgery right now. I want this vision back, and otherwise you give my money back. I told, no, you come, I will not go inside your eye, I will do the laser. So I did LASIK in her, and she was glass free, 1.75, very, means only after 24 days of post cataract, I did her LASIK very excellently. Now she is also happy. 1.75, you can precisely give the refraction and refractive error you can correct in these patients. So LASIK is also a good option post cataract, or you can do a PRK also. So many are not convinced that you are giving the suction on a 21 day or 1 month post operative, but really saying nothing will happen, no wounds get opened. This is actual case after 21st day, because you cannot, some paper says that 3 months you have to wait for the lens and incision has to settle. But 3 months, a cataract patient sitting on your head, I don't feel that's a good idea. So better I have taken the risk, I have opened, I have done the LASIK, and patient is happy. So, and some cases like cornea-based redialing of the IOL, sir has already shown. So thank you very much for your patience talking. Thank you.
Thank you, Dr. Deshpande. That was a great talk. We now have our guest speaker, Dr. Shibu Arke, who will be speaking to us about bridging the gap between vision and precision.
Respected Chairperson, Dr. Nitin, senior faculty members, and my dear colleagues. At the outset, I would like to thank AIOS and APO for this opportunity to be here. Myopia, as we all know, is on a global rise, and it is expected that in the this year,
around 52% of the world population is going to be myopic, of which nearly 10% are going to be in the high myopic range. The journey to correct myopia, especially the high myopia, was started long ago, long before LASIK was even thought about in 1953 by Strampelli. But his design was, as we all know, based in the anterior chamber, and it met with a lot of challenges, especially damage to endothelium and the pupil, and also the angle. This was basically because of the improper design, sizing, and of course the material. And through the ages, several attempts were made to keep this at various locations. The angle of the anterior chamber was one sort of the location. Iris fixation was also tried, but each met with different kind of problems. Ultimately, the breakthrough came when the phakic lens could successfully be placed within the posterior chamber. And this was safe because it was quite a safe distance from the endothelium. It did not disturb the iridocorneal angle, and also it was cosmetically very acceptable because it was not visible to the naked eye. And so today, I would like to present about the refractive implantable lens, which has been designed and researched and manufactured by the Appasamy Associates. I have no financial interest in this. It is a single-piece foldable phakic IOL. It is placed in the sulcus. It is made of hydrophilic biocompatible material. It comes in an overall length ranging from 11.5 to 14 millimeters in increments of 0.25 mm. And it has a fixed vault of 400 microns to 700 microns. It has got a central hole for aqueous filtration with 2 peripheral holes, and also got marker holes in its foot plates for identifying the unfolding. Just to compare it with the Collamer lens that has been predominantly been used earlier, the thickness is about 127 to 390 microns, whereas the Collamer is about 100 to 200. The vault is about 1.62 to 1.91. The Collamer lens doesn't have a fixed vault. The filtration holes are comparable. The overall length of the RIL is 11.5 to 14 with 0.25 increments. The Collamer has got 4 standard sizes. The toric rotation required for the RIL is less than 10 degrees, whereas the Collamer requires up to may need up to 22 degrees of rotation. So the preoperative data that is required, especially as for all phakic lenses, essentially the same, not much of different. The online calculator is not yet been launched, but it's going to be very soon launched. Presently, we send the preoperative data to the company and they calculate it, but very soon this is going to be launched. This is just the prototype of what is going to be launched. What I want to highlight about the RIL is especially the ease of handling, because as we saw in the comparison, this is a much thicker lens. So one of the problems of the Collamer lens is the folding of the lens, which sometimes leads to crumpling of the lens within the cartridge. Here, if you are a regular phacosurgeon, you can just use your regular hydrophilic cartridge. You don't need a special cartridge, or you don't need any special instruments to handle this lens. The only main point is that you have to look at the leading position, the holes on the leading haptic on the right and the trailing on the left. You load it within your cartridge, and that is it. You're done and you're ready for implantation. So the first key point is the ease of converting from a phacosurgeon to a phakic surgeon is very simple with this, especially folding it and loading it is very simple. Coming to the implantation, I prefer to do with 2 side ports, one at 6 o'clock and one at 12 o'clock. I use intracameral lignocaine. The viscoelastic that I use is the low molecular weight, though currently there are people who prefer to use the high molecular weight viscoelastic, which easy to remove. It comes out as a single mass. But if you're not a phacosurgeon who's routinely used to high molecular viscoelastic, maybe you should start with low molecular weight viscoelastic. When you begin, the preferred incision length would be around 2.8 to 3 millimeters, but you can take it down to even 2.2. It's possible to implant to 2.2. And again, deepening at the site of implantation. Now, one of the key points I want to highlight about RIL in comparison with collamer lens is you can even boldly shoot it from the tunnel. You can have an incision-based delivery compared to the collamer lens where you have to take your injector right up to the middle of the anterior chamber. Otherwise, there is always a risk that the lens may flip or it may rotate as you shoot it from the tunnel because of the extreme flexibility of the material, which is very thin compared to the RIL. Only you need to keep watch that the leading position hole is on the right and the trailing position hole is on the left, and that is it. And the other key point I want to show and highlight here is that compared to the collamer lens, you don't have to even deliver it on top of the iris. You could even take it into the sulcus because in a collamer lens, because of the extreme thinness of its footplate, there is a risk that if you inject it to the sulcus, the footplate gets folded and it remains folded in the sulcus. And that can lead on to the lens not being stable in the sulcus and sometimes coming into the anterior chamber, auto-subluxation into the anterior chamber. Whereas in the RIL, because of thicker haptic, there is no risk that the haptic gets folded or of auto-subluxation into the anterior chamber. The next key point I want to show in this implantation, in a collamer lens, you are strictly warned not to cross the optic because there is always a risk that the optic can get damaged if you take your instruments across the optic. Whereas this being a regular hydrophilic lens, you can use, and I also showing a Simcoe being used because I wanted to show that this is in the reach of a regular normal surgeon who may not even have a phaco machine. He can as well do this. And you can boldly wash over the optic, touch the optic. You can, nothing is not going to damage the optic in any way. So the ease of implantation is very good in this lens. Coming to a brief about my experience with RIL, my patients have ranged from the age of 18 to 45, spherical equivalent ranging from -6 to 23, cylindrical power up to 4.25. Looking at the post-operative results, at 6 months, most of my patients have been within 0.5 diopters of emmetropia, both in sphere and cylinder, and they have maintained the spherical equivalent at a follow-up of 6 months or more. Preoperatively, about 70% of my patients had above 1.5 diopters of astigmatism. At 6 months follow-up, more than 95% of the patients, they maintained the correction within 0.5 diopters of astigmatism. And there were no IOP spikes which were noted either in the early or in the long-term follow-up of these patients. So in general, phakic IOLs present a distinctive advantage over corneal refractive surgeries. There is tissue preservation. It can be, and the second point being that it can be used to treat extremely high levels of myopia and astigmatism. And then, of course, the quality of life. It provides better quality of vision. There are no issues like dry eye. There is no induced higher order aberrations. It has got a long history, as I said, starting from 1953. And there are no added complexities in future IOL power calculations, especially as you see in post-corneal refractive procedures. And of course, it is easily reversible. You can always remove it anytime you like. So in my experience with the Apasami's refractive implantable lenses, they had very stable refraction postoperatively up to the follow-up of even 1 year. And they achieved preoperative best corrected visual acuity up to 95%. None of them developed cataracts or any other iris-related problems. None of them had any early or late IOP spikes, and none of the patients required explantation. So in conclusion, I would very confidently recommend Apasami's RILs as a choice of your phakic IOLs. Thank you very much.
Thank you, Dr. Varke. Since all the talks are over and we have adequate Yeah, so we'll
Yeah, sure.
open the forum to talks, to questions. So anyone with any questions to any of the panelists is welcome to. Can the mics be given over there, please?
Yeah.
Sure, sir.
I'd request all the panelists to come up on the dais. Dr. Rupal, Dr. Shilpa, Dr. Nasta.
So one question, Dr. Shibu, was,
Yeah.
you said this lens is thicker than the star ICL,
Exactly, yeah.
and it also has an angulation.
Yes.
So have you done some angle studies to see post-operatively whether any of these patients are developing angle closure?
Yeah, I have not personally done, but we have data from what the Appasamy company has done. And so what they
For
have
me,
done.
it's a concern because if it has an angulation, it's going to lift the iris forwards. Also, the lens is thicker. Yeah, iris dispersion, chafing, all these things can happen, theoretically at least.
No, that is what. So ideally, see, we are selecting the cases based on the angle studies and the AC depth. So we are not putting it in cases where the AC depth is less than 2.95 mm. That's the recommended AC depth.
Internal?
Internal, yes, endothelium.
Oh, that's quite high,
Yeah,
2.95.
yeah. So that is what we are doing. So the chance, so the advantage is that since your vaulting is fixed, you don't, it is forgiving for slight, variations of your white to white. Unlike your collimator lenses where if you are precisely not on the dot for white to white, the vault can keep on fluctuating. But since you have a fixed vault here, your white to white can be slightly forgiving to some extent.
And have you compared with the IPCL?
Not yet. We have not done a study comparing with IPCL, but we intend to. Yeah.
Question for Dr. Sandeep. I mean, though you have debated against, the Sulcoflex lenses, you have in favor of IOL exchange, but I'm sure you must have done a lot of Sulcoflex also. So in your experience, what is your experience of Sulcoflex?
My personal experience of Sulcoflex was mentioned in that last slide. I have done so far only 2 Sulcoflexes, and I decided not to do it in the future unless I was compelled to. The reason being the quality of vision. Both the patients said that the moment they get into a hall or the street where there are lights, they start seeing these vertical streaks, which is coma because of light getting reflected between those two. So there is a genuine issue with the quality of vision, which I feel. And what you can get with a single IOL is definitely a much better thing. Now I'll tell you where I do sometimes the piggyback is sometimes you have very high hypermetropes where the power of the IOL comes to plus 55, plus 58. Yeah, there are.
So it's a planned primary procedure.
Non-ophthalmic eyes. So there what I do, I take the Alcon 40 diopter lens, okay, and I put the primary lens in the back, okay. Then there is a formula to calculate the add-on. And using that formula, then I add the second lens in the sulcus, which very often, which very often is a 3-piece lens, okay. So that's how I do.
But Dr. Sandeep, as it is, it's such a high hyperopia. What about the angle then?
Yeah, so the thing is the angle is narrow to begin with, but once you make him pseudophakic, the angle deepens. So you can easily put it. Yeah, yeah. Because see, I have even tried that 60 diopter lens made by IOCare, okay? And there again I was concerned about the quality of vision, So I think this is better, the 40 plus whatever. Use the maximum that you get and on top. SA60 is available in 40 diopters. Dr. Ramurthy is here, he can highlight.
Phakic IOL to be also a good alternative to Sulcoflex. Phakic IOL, so star ICL.
As a piggyback lens.
As a piggyback lens
Yes.
is a good alternative.
Yeah, it is. Dr. Ramurthy would like to teach us something. Yeah.
Can you give a mic there, please?
No, I completely agree with you, Sandeep, in the sense that this is exactly what I do. Because the normal cataractous lens is almost 5 millimeter, 4 to 5 millimeters in its anterior-posterior diameter. And when you, even your thickest of intraocular lenses is just about 1.5 millimeters. So when you remove the normal lens and place the pseudophakic lens, automatically there's enough space for two. And none of the formulae really work for these extremes of IOL power calculation. So when you have a 40 diopter lens inside, if you have minus a plus 7 diopter residual power, the simple for calculation is 7 into 1.5. So a piggyback lens of 10.5 goes in and you get fairly accurate results. I think the main reason we don't go for that plus 60 diopter manufactured lenses is, though it's possible, high amount of spherical aberration that can come with that.
That's right.
And
Quality of
second
vision
thing
is
is you are
very
never
bad.
sure about what is the power of the lens you need to implant.
So in such cases, can you put both in the bag if you're putting a three-piece?
No.
Or can you put the haptics in the sulcus and then put the lens in the bag?
The reason piggyback lenses initially went into disrepute is because of trying to put both the lenses in the bag. There's interlenticular fibrosis that happens. That's called the red rock syndrome. And you have to explant the whole lens with the bag. So it's always the initial lens and the second lens have to be of a different material. It's usually hydrophobic and the hydrophilic in the second lens. First lens goes in the bag and the second lens in the sulcus.
So I think the general consensus is IOL exchange. If not, then a piggyback IOL. If not, then a LASIK. Correct? Would that be the order?
No, I would put it as LASIK as a
LASIK
second
for-
option, and then the piggyback IOL.
Okay, but the first would still be an IOL exchange.
Definitely.
Yeah.
Yeah, you wanted to ask something?
Like trifocal lenses. So if we put a trifocal and have a refractive surprise, is LASIK a good option?
You're talking of post-LASIK patient with a trifocal IOL, and now he's got a refractive surprise.
No. Generally, post-LASIK, they say that we should not put a premium trifocal considering the aberrations it has created. So is it possible that if we put a trifocal lens and get a refractive surprise, we do LASIK? So the spherical abrasions that would happen.
No, I don't.
No, she's asking. Her question is that in case of a primary trifocal IOL in a virgin eye, if there is a refractive surprise, can you use bioptics in the form of
You
LASIK
can.
to correct it?
Address the aberrations.
So it is actually not a fact that you get a lot of induced aberrations post LASIK. Today's profiles are created in a way where induced aberrations are limited to a great extent. So it was true with the older LASIK, not true anymore. But for your case, definitely you can use LASIK as a reparative tool.
Yeah, you're talking about the AC depth and the white to white. Yeah, whatever you are routinely. No, the lens vault is not chosen by us. When you it's when you give the white to white and ACD and other K readings and other parameters, so the software generates the calculator itself will generate. So we don't have a choice that we choose this vault or that vault. So yeah, depending on the power of the lens and the size of the lens, the volt is automatically generated by it.
So Dr. Shibu, what is the volt? How much is the volt?
That's what, as I showed in the presentation. Can you specify that volting? How much is it?
Okay. And what's the longest follow-up that you have, Dr. Shibu?
Yeah, my longest follow-up is 1 year. 1 year.
So, no commercial interest, but I've been using since almost 16 years now, Star ICL. I do use a few IPCL and biotech, but I've really not used the Apaswami one.
Are there any more questions to the panel?
Yeah, I wanted to ask the Autofocus Pro you mentioned, how does it work?
So Autofocus Pro na, it's designed like the lentis only. So it's got like a press biopic design, and every point is going to see far and near both. But the key here is that the transition zones are designed in such a way that you get a very good depth of focus. So practically, we tell the patient that if you want to understand how it is, when you're going on a platform for catching a train or something, you see the flight of stairs, you see them all the way, even the top one and the bottom one, you'll see them equally well focused. So it's slightly different. That's how it is.
Basically, it's like a progressive lens. The design is
Yeah.
like a progressive lens. You have to place it horizontally.
Yeah.
It's a large diameter lens, and the most important thing is to place it horizontally so that the progressive segment goes into the lower segment.
So it's exactly like a progressive chashma with those two side things.
But with your small pupils, how
Yeah,
is it going
pupil
to work?
dependent it is, no?
Nikhil, you
With the small pupil, I mean, which most of us are, you know, senile meiosis is also there. How is it going to work?
The smallest zone in the center, I think, is 0.85 millimeters. So
Yeah.
it will focus well in the distance in the center. And then it starts.
And you have to aim for a bang emetropia. Don't do any corrections, myopic, hyperopic, nothing. Bang emetropia.
It's not pupil dependent at all.
No.
So that, since there are no more questions, that brings us to the end of this IC. I thank all the audience for having taken time and attended this IC in a large number, and thank you all my panelists.